Now, in our next module, we're going to turn our attention to look at diseases of the coronary arteries. Now, I must admit, because of the way this lecture is set up, we actually have missed a big gap. There are a lot of vascular structure, as shown in one, for pulmonary embolism. There's certainly a lot of pathology in the chest that involve the aorta, the vena cava, the pulmonary veins, and so forth. But because we're going to turn our attentions toward a relatively unique aspect of CT and what we can do today with cardiac synchronizations, we're going to dedicate modules to look at disease of the coronary, highlight what CT can do for us today. Now, when we think about imaging the anatomy of the coronary arteries, we really had a relatively small set of disease in mind. I would say 90% of the times we'll be looking at atherosclerotic diseases of the coronary artery, so simply called the coronary artery disease. Now, then, in addition, CT could help us to look at various treatments that we use for coronary artery disease, such as bypass graft and stent patency. Now, there are a small number of vasculitis that can involve the coronary arteries. The most famous one is Kawasaki disease. And this is one that can produce both stenosis as well as aneurysm of the coronary arteries. There's a fair variety, although rare, presentation of congenital coronary anomalies. In a limited amount of time, I'm going to present a few examples to you, although you can find references with a lot of other congenital abnormalities as well. Now, coronary artery disease is pretty much a fixtures in developed countries such as the United States and Europe, but unfortunately, it's also increasing in developing countries, principally due to smoking. It's also related to obesity, related diabetes. These are two major contributing factors to coronary artery disease or atherosclerotic disease of the body in general. Now, as we know from medical school, the typical manifestations, the prototype manifestation of coronary artery disease is a loss of perfusion to the myocardium, resulting typically a symptom of angina. When the loss of perfusion is severe enough that there is not enough oxygen or metabolites, even to sustain the viability of the myocardium, that part of the heart will undergo infarctions. Just like we saw earlier, pulmonary infarction, in this case, is the myocardial muscle infarctions. When it's infarcted, that part of the muscle is gone, and there is no regenerations. Acutely, this can produce rhythm disturbance, and patient can die acutely from sudden death because of arrhythmia. Chronically, as the myocardium is injured, and depending on extent or repeated injuries of the myocardium, you can set up into ischemic heart failure. That is, the remaining muscle is just not enough to produce the kinds of cardiac output we need to sustain the usual activity of that patient. Now, there are a large number of diagnostic tools for coronary artery disease developed over decades. Generally separate those that are angiographic in intent, and these are used to look at the stenosis and the coronary artery anatomy, versus stress study. These are looking at the consequences of abnormal perfusion, reduced perfusion due to stenotic lesions. Now, stress tests usually mean that the patient had some kind of stimulants to the heart to make it pump faster, by exercise, for example, or by pharmacologic means such as dobutamine. There are also stress that will alter the perfusions patterns in the heart, such as by adenosine. Suffice to say, the interpretation of this kind of stress study requires to look at what the baseline non-stressed presentations on the diagnostic study and compare that with the stress presentation of that study. And the difference is if they were abnormal, might well indicated that there is myocardial deficit in perfusion, suggesting coronary artery disease. Now, stress can, the myocardial perfusions can be looked at by electrocardiogram, but it is a relatively insensitive technique and is not now usually employed. The two most important variety of stress study that we do today are echocardiogram, usually with stress of dobutamine, or myocardial perfusion scan, in this case with single photon emission computed tomography, or positron emission tomography PETs, or even with MRI. All right, now for techniques that we want to look at stenosis with the intent to intervene, catheter angiography is the gold standards. Today, catheter angiography not only look at the anatomic structures of the luminal patency, It's also assisted by other means, such as intravascular ultrasound to look at plaque compositions. They also use very sensitive pressures wired going down to stenosis or diffuse disease of coronary arteries to measure the fractional flow reserve. And this is a way to look at otherwise apparently not critical stenosis, but because there are enough tandem stenosis, actually produce a drop in the perfusions. And the fractional flow reserve allow us to review that. Now, the new player to all this is CT coronary angiography. The reasons why it become an important thing is because while catheter angiography is the gold standard, it is pretty invasive. There are definitely fixed amounts of complications, including strokes, that the patient may experience, not to mention that these tests are expensive. So it will be really beneficial from a clinical practice point of view if we have a way to look at coronary arteries without having to go through the expenses, the time, and the risk that the patients may experience otherwise. Now, a typical coronary CTA protocol uses a technique of prospective ECG gating and retrospective ECG gating that I discussed earlier. The patient generally had to be prepared. The reason for that is because as fast as scanner we have today, typically the images still look better if we can slow down the heart, so the motion artifact is reduced. We typically prepare the patient with either PO atenolol or IV metoprolol while the patient is on the table, with the target of reducing the heart rate to lower than 65 beats per minute. About 2 to 3 minutes before the scan, we will administer a sublingual nitroglycerins at 0.4 milligram dose. And the purpose for that is to dilate the normal segments of the coronary arteries, increase the contrast, perfusion, and opacification of the coronary system, and also exaggerate the differences between the fixed stenotic lesions compared with the open coronary arteries. Typically, a patient will need a 20 gauge well-secured IV because we'll be injecting at high rates of 5 milliliters per second. And then under contrast administration, we'll monitor, typically at the ascending aorta. When the contrast arrives, that's when we trigger the scan. Either we're going to do the retrospective gating or prospective gating, depending on how stable the patient's heart rates may be. We'll scan from the carina, that is from the anterior skull. We can see the airway, the trachea bifurcations at the carina. From that point, we'll scan through the base of the heart. Again, we generate hundreds of images. At this point, we use 3D post-processing to tease out the coronary arteries, to look at them carefully for cross-section of stenosis, as well as abnormal longitudinal course. So to give you an example, here's a 67-year-old man presenting atypical chest pain associated with non-specific EKG changes. The coronary CTA does show mixed calcific plaques, some of these dense area, for example, and soft plaques, such as these areas right here. In fact, there is a pretty tight stenosis right at the proximal right coronary arteries. And because of this, the patient will went for the cath lab. On the cath angiogram with injection in the right coronary artery, indeed revealed to 70% stenotic lesions right here. For the patients on the table, the interventional cardiologist deployed a stent right here, outlined by the red arrow, and then the post-stent angiogram shows pretty much a restoration of the pain lumens in the right coronary arteries. Here are two 3D reconstructions of a coronary bypassed graft. And this is a left anterior mammary artery graft, comes down, and it bifurcates. And then one of the grafts is surgically sutured to the LAD, and the other one is surgically sutures to the left circumflex artery. Now, there are a lot of clips in between, and quite often these metallic clips can obscure small parts of the graft. And if there were an unfortunate stenosis in those areas, we may not be able to see it. But the fact that there's contrast coming from the origins all the way to its destinations typically tell us that the graft is at least patent. We might not be able to say something about stenosis, but we know that it's not occluded. Here's an example of a right coronary graft coming from the ascending aorta, and you can see there is in fact a tight stenosis at the suture sites between the graft and the ascending aorta. Now, the road to coronary CTA is still being defined. We now know that it is a very good tool to rule out coronary artery disease for patients with atypical chest pains. The reason for that is when patient had no coronary artery disease, meaning there's no calcific plaques, no soft plaques, the coronary arteries can often be seen very well in its entire territory. And when we can see it very well and we see there's no disease, negative predictive value is greater than 98%. That there's no coronary artery as a disease as a cause of that chest pain. And that's extremely valuable, typically in the ED settings where patient coming with chest pain, they don't know whether it's coronary artery or not. Now, once patient with coronary artery disease, the question then turns into how do we grade a coronary artery? Is that hemodynamically significant, something that needs to go to cath lab to be treated? Here, the coronary artery CTA and its performance is more problematic. The reason for that compromise is because coronary calcium often obscures the lumen. And if the patient has very extensive coronary calcific plaques, there are many regions where coronary arteries simply cannot evaluate. When patients are stented, certain type of stents, especially those that are associated with stainless steel stents, we often cannot see inside X-ray, cannot get through inside to produce a yes or no about the luminal patency. And then we cannot evaluate collateral arteries. And when there are long-standing ischemia or even infarctions, collateral arteries may be developed in a chronic setting to allow other parts of the myocardium to get nourishment without its normal coronary origins. Unfortunately, these coronary collateral arteries are typically very small, and the coronary CTA is not good at evaluating the pathway or adequacy of these collateral arteries. Now, as we've seen a little bit earlier, in fact, that match between the right coronary artery as well as the calf, there's a tendency for coronary CTA to overestimate stenosis. There are a variety of reasons why that could be so, but in general, we'll see a stenotic lesion tighter in CTA than we see for calf. Now, switching gear away from coronary arteries, we're going to look at other applications. Here are two examples of patients who suffer from Kawasaki coronary disease. Now, as you know, this is a disease that affects young children, typically up to age 5 or 8 or so. The sequelae of developing coronary aneurysm, however, can persist for the rest of their lives. Here's an example on the left side with a partial eggshell calcifications of an aneurysm that's 8 millimeter in size. Fortunately, there are pretty clear perfusions all the way from the left main down to the left anterior descending artery, and there's no internal filling defects, just clots. Typically, an 8 millimeter in size, these patients will be anticoagulated, just in case they will form clots that cause myocardial infarctions. In addition to aneurysm, they can produce stenosis. In this case, the patient had a nearly completely occluded left main coronary arteries. This segment of LAD, in fact, is supplied by a collateral developed from the right coronary artery, and then retrograde filled the left anterior descending as well as left circumflex artery. You can see the right coronary artery here is also irregular and have been dilated. This came from also the Kawasaki disease. So both stenosis as well as aneurysm can develop. As the last part of the discussion about coronary artery, we'll talk about certain patterns of coronary congenital abnormalities. Some of them could be clinically important. Now, abnormal arrangement of coronary artery coming off from the aorta is not that uncommon. We believe that it happens in about 1% of the populations. In most configurations, they are usually benign. That is, they don't cause physically manifested problem. And if you do see them incidentally, there's nothing to be done. So one of these benign examples is here. This is the right main coronary artery coming off from the aorta sinus valsalva. Now, there's a vessel that wraps behind the aorta. This is the right atrium and left atrium. It wraps around it and goes around and enters into the left atrioventricular groove. This, in fact, is a left circumflex artery. It should have come out from the left main coronary arteries here, but instead it comes up all the way around from the right coronary sinus. That is where the right coronary artery comes off. This is called a retroaortic course of the left circumflex artery. It happens probably about 0.1 to 0.4% of the population, and is completely benign. Now, there are malignant varieties of coronary anomalies that we found in autopsy series. That could be a result of sudden death, into sudden death. Typically, these kind of abnormal coronary artery has a course that's sandwiched between the aorta and the pulmonary trunk. This is called interarterial course. And in this reconstruction, in fact, can see that coronary artery is being squeezed between the two. It is hypothesized by that obstruction, so the coronary artery can set up ischemic changes that may be triggered by sudden death events. Typically, patient will experience clinically sudden death in teenage years or young adult, quite often during exercise. Now, the abnormal arrangement that is going between the aorta and the pulmonary trunk can involve the right coronary artery or the left main coronary arteries. So in the top two slides here are a right coronary arteries going between, coming off from the left side. In this case, it's coming off from the left coronary sinus. In this case, it came off the left main coronary arteries. Similarly, the left main coronary arteries can come off from the cusp sandwich between the aorta and the pulmonary trunk, or that it can come off from the right coronary artery itself with the same course going between the two. So when you do see, either incidentally or seeking for coronary abnormally, a coronary artery that goes in between the aorta and pulmonary arteries, typically these are significant, especially in patients with symptoms and especially in patients who are young, in teenage years and young adults in 20s. Well, thank you. We finished our module number 4.